Picture this. A patient walks right into your clinic with a red, watery eye. They're complaining of irritation, burning, and some blurred vision. Now, at first glance, you might be thinking, okay, just another case of dry eye disease. But then, you ask them to close their eyes. And suddenly, the entire clinical picture completely changes. They actually can't fully close their lids. So, would you know what to do next? Welcome to this explainer for everything optometry. I'm your host, and today we are tackling Lagophthalmos. We're going to treat this less like a dry textbook review and way more like a clinical detective challenge. Our goal? Giving you, the optometry students and clinicians out there, the exact exam-focused skills you need to solve the mystery behind the incomplete blink.
Here's our investigation plan for today. We'll kick things off with the detective challenge. Interrogate the symptoms, identify our main culprits, assess the ocular damage, make those crucial referral decisions, and then wrap the whole thing up with a clinical case quiz.
Section 1. The Detective Challenge, a deceptive presentation.
As we established in our hook, this is a condition that absolutely loves to hide behind the symptoms of common dry eye. It's super deceptive because the secondary symptoms usually mask the primary mechanical failure. So let's formally define what we're actually dealing with here. Lagophthalmos is simply the condition where a patient cannot completely close their eyelids. Think of your eyelids like the windscreen wipers of your eye. When they stop working properly, the surface becomes exposed, the tear film gets completely disrupted, and the cornea takes damage. And that leads to a really serious risk of corneal ulceration. So the central question you absolutely must carry through this entire explainer is this. A patient cannot fully close their eye. Is this simply an eyelid problem, a facial nerve palsy, Myasthenia gravis, or is it something much more serious? Let's build out our diagnostic framework to find out. Section 2. Interrogating the symptoms, the right questions. Look, taking a good history, that is your absolute best diagnostic tool. You aren't just making small talk with the patient. You're actively hunting for clues to unmask the culprit before you even shine a light in their eye. Check out how directly these specific history questions link to major systemic diseases. You obviously need to ask when it started and whether it was sudden or gradual. But pay attention to these specific clues. If they report double vision that gets worse when they're tired, or if they casually mention limb weakness or trouble swallowing, you should immediately be highly suspicious of Myasthenia gravis. If they have a medical history of an overactive thyroid, well, thyroid eye disease is your prime suspect. And definitely don't forget to ask about previous trauma or surgery to the face, because skin scarring can physically pull that eyelid down, causing an ectropion. Okay, let's dive into this critical warning sign. While you're chatting and taking that history, certain answers should literally set off alarm bells in your head. If the patient reports blurred or reduced vision, pain in or around the eye, or really any form of diplopia, your referral urgency automatically shoots up. These aren't just mildly uncomfortable symptoms, they're massive red flags. They tell you that the ocular surface is already compromising their vision, or that a severe systemic issue is actively at play.
Section 3. Identifying the culprits, the lineup.
All right, it's time for the physical examination lineup. Your exam needs to answer one very simple question. Why on earth isn't this eyelid closing? You'll need a highly structured approach here, checking visual acuity, performing a cover test, checking ocular motility, and doing a thorough external examination. First up in our lineup is Ectropion, where the lower lid turns out away from the globe, just like you see on the far right. Sometimes the eyelid itself is the mechanical problem. Now, this can be an involutional issue just due to age, a cicatricial issue due to that skin scarring we talked about, or a paralytic ectropion secondary to a 7th cranial nerve palsy, which you probably know as facial nerve or Bell's palsy. If there's a facial droop on one side and they simply can't blink, that 7th nerve is definitely your culprit. Moving on, our next major suspect is thyroid eye disease, or TED. Notice the really severe lid retraction and that distinct staring appearance of the eyes here. That bulging, known clinically as proptosis, is physically pushing the globe forward so much that the eyelid simply cannot stretch far enough to cover it during a blink. This mechanical mismatch leads to some really severe exposure. And then, oh boy, we have the tricky diagnosis, Myasthenia gravis. This is the patient who sits in your chair and tells you, some days it's just worse than others. Myasthenia doesn't read textbooks. Okay? It changes constantly throughout the day. What you're looking for here is a bilateral ptosis that is fatigable, meaning if you ask them to maintain a prolonged upward gaze, you'll actually see those eyelids visibly start to droop. But the absolutely crucial point here is that you must look beyond the eye itself. Fatigable ptosis isn't just a tired eye, it's your cue to ask about systemic issues like limb muscle weakness and problems swallowing or breathing. Section 4. Assessing the damage, the ocular surface. So once we've identified the likely culprit, we have to figure out how much damage they've actually caused. And this is where we create a sense of urgency. I literally cannot stress this enough. Assessing lagophthalmos requires an external examination with a slit lamp and, crucially, fluorescein installation. A super common clinical mistake is entirely missing corneal staining, just because the practitioner skipped the dye. If the eye isn't blinking properly, the cornea is exposed. You absolutely must assess the risk of corneal ulceration, and fluorescein is the exact tool you need to do it.
And this brilliantly illustrates exactly what we're looking for. Under the blue light, you can clearly see these bright green areas of inferior corneal staining and punctate epithelial erosions. The truth is, the longer the cornea remains exposed like this, the greater the risk of permanent damage, infection, and ultimately ulceration. Seeing this specific pattern, it changes everything about your management plan.
Section 5. Referral Decisions. The Management Plan. As I always say, the best clinicians don't just spot the Lagophthalmos, they figure out why it's happening, and they formulate a rock-solid, safe, exam-focused referral plan. Let's look at the traffic light system for these conditions. The absolutely crucial point here is how the clinical signs dictate your timeline. Thyroid eye disease, that warrants an urgent 1-week referral. If you suspect a 7th nerve palsy or myasthenia gravis, you're looking at an urgent 2-week referral, mostly due to that lurking risk of corneal ulceration we just talked about. Now look closely at Ectropion. This condition has multiple referral urgencies. If there's corneal fluorescence staining present, boom, it's an urgent 2-week referral. But if the cornea is perfectly healthy with 0 staining and the patient just wants the anatomical position fixed for comfort or cosmetic reasons, it drops right down to a routine referral. See how that works? The staining completely changes the management.
Section 6. Clinical Case Quiz. Test your skills.
All right, it's time to put on your detective hats and test those newly refined clinical skills with some rapid-fire revision. Case number 1. You have a patient whose lower eyelid is turned outwards. You've done your due diligence, instilled the dye, and the fluorescein staining reveals a completely normal, healthy cornea. Think back to our traffic light system. What is the correct referral urgency here? I'll give you a second to think about it.
Well, if you said routine referral, you hit the nail right on the head. Because the cornea isn't actively taking up stain, that immediate threat of exposure keratopathy and ulceration is entirely absent. It's a structural eyelid issue, an ectropion, that definitely needs addressing, but it is not an acute emergency.
Okay, moving right along to case number 2. Your patient presents with bilateral drooping eyelids that get noticeably worse when you ask them to look up for an extended period. During the history taking, they casually mention that they've been having trouble swallowing their food lately. So, what is the most likely diagnosis here, and what is your referral urgency?
The answer? Myasthenia gravis. And that requires an urgent 2-week referral. The fatigable ptosis combined with that systemic muscle weakness, like the swallowing difficulties, is the classic textbook presentation, even though we know MG hates textbooks. The urgency is really driven by both the systemic nature of the neuromuscular disorder itself and the significant lurking risk of corneal ulceration from that incomplete lid closure.
Before we wrap up, I really want to leave you with this final, absolutely vital takeaway. A patient who can't close their eye properly may not look like an emergency, but if you miss the underlying cause, the consequences can be significant. Remember, Lagophthalmos is a sign, guys. It's not a diagnosis in and of itself. Protecting that cornea is always your immediate priority, but identifying the true culprit, whether it spells palsy, thyroid disease, or myasthenia, is what's going to make you an exceptional clinician. And with that, we're wrapping up our investigation into Lagophthalmos. I really hope this structured approach has sharpened your clinical reasoning and has you feeling way more prepared for both your exams and your actual practice. But I want you to ask yourself, what other deceptive symptoms are lurking right now in your exam chair? If you found this explainer helpful in cracking the case today, be sure to hit that subscribe button for everything optometry so you never miss out on more of these clinical explainers. Keep asking the right questions, always remember to use your fluorescein, and I'll see you in the next one.